Good evening. I'm Dr. Sucheta Mehta, Head Medical Affairs Super Specialities from Cipla. And today we are here to talk a bit about and a lot about ovarian cancer. There's a lot of public awareness that is created on breast cancer, lung cancer, but there's not much discussion that's happening on ovarian cancer. Ovarian cancer ranks third in all women cancers in India. It has a high mortality. The 5-year survival is only 45%. And if you see the 10-year survival, it dips down to 15 to 30%. One other reason why ovarian cancer is not understood much by general population also is the ambiguous symptoms. So this September, which is the Ovarian Cancer Awareness Month, Cipla Oncology is all geared up to make a difference by bridging the gap between the diagnosis and advanced ovarian cancer care, that is, from detection to action. Today, we have a chat show between we have a gynac, the Professor Shweta Mittal Gupta, who's an IVF specialist from Delhi. And we have a medical oncologist, Dr. Priya Tiwari, who's a head and senior consultant from Delhi, a medical oncologist. Both are experts in their field and have many decades of experience between them. So today I invite both the experts to share their experiences because every woman matters. Over to you, Dr. Priya and Dr. Shweta.
Thank you, Dr. Sucheta, for a very kind introduction. And hello, Dr. Priya. We had a little time to chat before we went online. Let's start the ball rolling. And we were told that it's like a chat show, and we'll be having some questions coming in. And most welcome. See, to my knowledge, let's begin that to my knowledge, I kind of understand that ovarian cancers will be more seen in women who are obese, or we've always read that, delayed marriages or nulliparity. Very important is family history of ovarian cancers. We have the genetic linkage. And then, since I'm in the reproductive medicine unit, and then we always have this in mind that, we tell the patients that incessantly don't keep on having normal ovarian induction, because we get patients who have had like 15 cycles of clomiphene in the past, and now they are looking for something more. So we need to offer them gonadotropin. So we need to limit, and we need to very actively move being in the reproductive medicine, keeping the overall risk of ovarian cancer on the lower side. So, Dr. Priya, could you add something more, that if you're seeing something else in the causation of ovarian cancers?
So I think it's very important to thank you, Cipla, for this initiation. It's very important to talk about ovarian cancer, because this is actually one cancer, not just one gynec cancer, but one cancer overall, which is actually talked very less. But as rightly said by you and by Dr. Sucheta too, that's one of the very lethal cancers. It is a lethal cancer. Why? Because of the deep-seated ovaries. Ovaries are very deep-seated organs, so the symptoms are not coming early. So that is why it's very important that at least the awareness should rise, so that people can be diagnosed in time. And until you don't start a discussion, there won't be any awareness. So that way the discussion has to start. And you have rightly pointed out the various risk factors on the ovarian cancer. So like we know that the cancer of ovaries is ovarian cancer. We are seeing that the ovarian cancer is actually on the rise. Now, we say that the cancer is on the rise maybe because of certain risk factors that we'll subsequently discuss. But it's also because now India as a country has capability to diagnose ovarian cancer, and also many other cancers. So even the tier 2 cities, the tier 3 cities have now the equipments and the facilities to diagnose ovarian cancer. And I think that is the main reason that why the incidence of ovarian cancers, now we are seeing in the OPDs more and more ovarian cancer patients too. 50 years back, we were not equipped with these, but yes, the incidence of ovarian cancer is now rising. Now, the important thing is, like I also mentioned, that ovarian cancer is a lethal cancer, and because 70% of the females are actually diagnosed either in the stage 3 or stage 4 cancer. So when you start having certain symptoms, a lady tends to go to a gynecologist, isn't it? So the sensitivity of gynecologists is very important to pick up these symptoms and investigate further and not to miss on the ovarian cancer. And that is why I feel that we should know what are the symptoms, when they should not be missed, when they should be investigated, and what is the investigation. The usual investigation to do is certain blood test and the ultrasound. So maybe Dr. Shweta, you can just touch upon with what could be the symptoms and how should we investigate. And since I think we have a lot of gynecs here, what are the findings in the ultrasound that will tell us that, okay, these are the findings that you should further investigate with MRI, with PET CT and a biopsy to say that yes, it could be an ovarian cancer.
So, the symptoms are very general. In the beginning, maybe they may be completely, unrecognized when she's harboring maybe a borderline tumor or a very early stage, a CM. Maybe there could be just very simple mild gastric symptoms or bloating going on or an unexplained weight loss going on. Sometimes, women diagnose it very late when they see that they have a bulge in their tummy, some abdominal distension is there. Very important symptoms are irregular menstrual patterns and postmenopausal bleedings are something which should not be ignored at all, I think. Now, the first diagnosing, how will you clinch is, of course, it's the easiest modality, which is an ultrasound. It's very important, I feel, that in all sexually active girls, we should do a transvaginal ultrasound because it's only with good, resolution of the ultrasound, good magnification, and ovaries being close to the vaginal probe that you will be able to pick up some masses. Otherwise, in obese girls, this can be missed big time also. So that is important. Now, if you see a solid mass or if you see multiple septations, you see excrescences, papillary excrescences, if you see the ovaries are stuck or bowels are stuck, if you don't have the sliding sign with ascites, then these are the, features which will be pinching. And then there is a classification of the ovarian tumors. So, you can have that classification if the ultrasonologist is a keen ultrasonologist. Now, once the ultrasound diagnose, then comes the role where we think that we'll do certain tumor markers, which I will ask Dr. Priya, that how does she judge that, which tumor markers have to be done. But being in the reproductive medicine unit also, I see a lot of younger population coming with cancer, especially one group I can tell you are testicular feminizing syndromes and Swyer syndrome, where we want to do a prophylactic gonadectomy because of lately in the last 1 year, whichever patient I operated on had a gonadoblastoma, though it was limited to the gonad, but it was there. Then I operated on, a yolk sac tumor in a reproductive age group woman. So I think what you need to distinguish is that which age group is coming with what kind of symptoms. So I want to know from Dr. Priya that, when you have these kind of suspicious masses, then what do you do further?
Okay, so Dr. Shweta, I think to start with, you touched very nicely upon the symptoms. And most of us are actually lost in the symptoms itself, but the understanding has to go very deep in that. To start with, ovarian cancer mimics the usually occurring symptoms of some bloating, early satiety, some vague discomfort in the abdomen. And yes, at the times there could be menstrual irregularities. So these are very commonly encountered symptoms, but if they are persisting, recurring, maybe like persisting beyond 3 weeks, 4 weeks, especially the GI symptoms, then I think a lady should promptly go and get herself investigated. Just because these are non-specific symptoms, they should never be ignored. Any recent onset symptoms, new onset symptoms should always be investigated. I think that is a very clear message that we have to give to the audience. And yes, I think the point of contact, you go to gynec and an ultrasound is done. And we just now discussed that what could be the red flags in an ultrasound. Important thing is that when you find these findings, how do you investigate further? Now, a very sensitive investigation, a modality is an MRI, okay? MRI will tell you the exact what is happening in the abdomen. So MRI is something that is now easily available and easily done. Now, based on the MRI, we tend to also do certain blood tests. Now, the problem with the blood test, or what is the problem with the so-called tumor markers? The most talked about tumor marker is CA125. We have other tumor markers also, like there is a clear cell histology of ovarian cancer where we see CA19.9 being raised. Then HE4 is another tumor marker. So tumor markers are, to put in simply, are the chemicals released by the tumors. The problem with all the tumor markers is to detect an early ovarian cancer, they have a very low sensitivity. Just to quote a stat, up to 50% of stage 1 ovarian cancer will have normal CA125. Okay, so suppose if you do an ultrasound and then if you just do a CA125, so if ultrasound says there is a problem, but if the CA125 is normal, then people will just get relaxed. Okay, this might not be cancer, but that is not the case. If the ultrasound rates if there is a suspicion based on an ultrasound, you should always investigate it. So MRI is the usual investigation that we offer. Sometimes there could be that the findings of ultrasound are so characteristic that maybe you can just simply do a biopsy. Okay. Now, one of the concerns about the biopsy is, and this is also one of the myths, people are very, very, very fearful of doing a biopsy. So what is biopsy? It's just putting in a needle. Right now you have ultrasound guided biopsy. You don't require opening of the abdomen. You can just do an ultrasound guided biopsy. So people have this fear that if you try to put in a needle, it will just blast and maybe spread in all over the body, which is not the right concern, isn't it? Which is a concern, but not the right concern. Because what happens is that we now have so many safe methods of doing a biopsy that it does not lead to spread of the cancer. Okay, so if you take the biopsy is ultimately the weapon which will help you to establish the diagnosis. Now, beyond biopsy, for any cancer, we also need to look at what is the way to actually see the extent of the disease. So by one modality, you are establishing the diagnosis, but for any cancer patient, we would also want to see the extent of the disease. Now, ovarian cancer is a cancer that has a very high predilection of staying in the abdominal cavity. Ovaries are the organs in our abdomen. So it has a very high tendency this is not a cancer that goes to the bones. It is not the cancer that goes to the brain. Many other cancers, they migrate to various parts of the body. So a good abdominal imaging is very important, but at the same time, ovary cancer can also lead to formation of fluid in your pleural cavity. Pleural effusions are quite common in the ovarian cancer. So that is why at least a chest x-ray, if you have done an MRI of the abdomen, then at least a chest x-ray should be done. But now what we are also seeing, the increasing role of PET-CT. Now people say that you just have CE-CT chest abdomen, you can also do a CE-CT chest abdomen. But there is data to suggest that the PET scan is much more sensitive in picking up the peritoneal disease. Ovarian cancer has a way of spreading along the peritoneal surfaces. So you see omental deposits, peritoneal deposits, deposits on the surface of the liver, on the undersurface of the diaphragm, and so on. Okay. So to see the accurate and the most sensitive, we are now saying that the current consensus is the PET scan might be much more sensitive to pick up these deposits. And at the same time, it can also pick up the pleural effusion. So there is the more and more guidelines are actually bringing the role of PET scan also in the ovarian cancer.
So Dr. Priya, I just wanted to put across one point.
Yes.
What happens is, since I see a lot of endometriosis and endometriotic cyst. Now I want all the gynecologists to know that CA125 is not a recommended tumor endometriosis, because the problem happens is it is just a marker, first of all, and it is only showing that your endometriosis is active. Now, if it was a true malignancy, CA125 would have been way higher. The levels would have been. Now, they normally, gynecologists, they see a level, say 50 or 60 CA125, and a very alarming counseling is done to the patient that you need a surgery. And so my advice is that when you are diagnosing endometriosis, you don't have to do CA125. Even if there's a report of CA125, and if you want some, you have a certain suspicion, I think a good MRI is helpful, but do not interpret CA125 unnecessarily, doing a negative counseling, and that becomes very alarming to the patient. And my second point is that many a times when I ask for an MRI, the report which comes says, kindly do clinical correlation. Now that's even more misleading, because we were dependent on MRI, right? We were waiting for MRI to say that this is an endometriotic cyst, most probably, but they have not given any diagnosis. They have just written it's a complex mass with T1, T2 weighted images. So my request is that if we have radiologists attending, or a two-way conversation. If you see a
Yes.
report like that, you must have a word with the
Yes.
MRI team that what is your impression? Because we have already done a good ultrasound is a very good method of picking up many findings. Now, on top of it, if we are moving ahead, we want to know whether it's malignant, if it is, what is the spread, and what is the, clinical staging, what we will do.
So I think you rightly mentioned very nice points, Dr. Shweta, and I think the whole discussion has to be that I think people are relying just too much on CA 125 as a marker, but mild moderate elevation does not say cancer, and negative CA 125 does not exclude cancer.
Yes.
So both way there, so the information has to go very clearly. And like you said, that sometimes even the imaging could be very equivocal. And see, at the end of the day,
I started doing HE4, and then we started
yes,
getting Roma index. And
yes,
then I realized that again in endometriosis, it
yes,
comes altered.
yes,
And we cannot be dependent on just we see some altered tumor markers and we come to a conclusion that this is abnormal. However, I think number one, clinical symptoms and correlating it with a good ultrasound is the first, I think, modality
agreed.
to come to some kind of a diagnosis, which should not be ignored. Dr. Priya,
Agreed.
tell me one thing. There's so much of hype, I think, after Angelina Jolie's case about BRCA, and breast cancer and genetic inheritage, and then link of ovarian cancer to BRCA. So could you throw some light that who needs to do it?
Yes.
Yeah, when to do
So
it,
I think
how to do it.
so I think that brings us to a very important question, and that you also touched initially, the risk factors of ovarian cancer. I think we should also be aware of the risk factors. It's also very favorite questions for the Viva of the medical Viva, isn't it? So any cancer is much more common with increasing age, and ovarian cancer is no exception. We see the ovarian cancer also rising after the age of 45 and 50 years. So increasing age is one of the risk factors. The other risk factor now we are realizing is the genetic predisposition. And there comes the example that you just now cited. It has been seen that for breast cancer and for ovarian cancer, a subset of patients, for breast cancer, it is like 5 to 10%. For ovarian cancer, it is around 20% patients. They have a genetic predisposition. Now, genetic predispositions means that you have certain genes which will increase, whose defects will actually increase the risk of having cancer. So the most commonly talked about, and the Angelina Jolie example that we just now discussed, was the BRCA syndrome. So BRCA, BRCA1 and BRCA2 are the ones which predispose a female for ovarian cancer. And there are many other genetic syndromes too. So there are many other genetic abnormalities which have a hereditary predisposition, like genetic abnormalities in ATM, CHEK, PALB2, and so on. So we have number of genetic abnormalities which can give rise to ovarian cancers. There are certain other cancers, genetic abnormalities, where you see not only ovarian cancer, but intestinal cancers, what we call as the Lynch syndromes. So you have BRCA syndromes, you have Lynch syndromes, and you have various other genetic abnormalities which can cause. So how do we say that somebody can have a cancer? So when somebody comes to you, this is a very common question. My mother had ovarian cancer, or I have ovarian cancer. So if my mother had ovarian cancer, can I get it too? Or if I have an ovarian cancer, can my kids get it too? So that these are the usual concerns. So how do we find that there could be that who should be tested for these tests? Currently, the recommendation is that for any ovarian cancer patient, you should always do a genetic testing, irrespective of family history, irrespective of age of the patient, irrespective of number of times the cancer has developed in the body of a patient. Okay. So every ovarian cancer patient should be tested for the genetic syndromes. But yes, we also see that if somebody, so the usual patients who comes and can have actually a very strong suspicion is that somebody who is young, because these cancers happen in old age. But if somebody who has developed cancer, say like in the age of 35, then we know that there is more possibility of these patients having a genetic predisposition. Then, of course, if you get a familial clustering, if you get in more than one generation occurrence of cancers, other family members also getting cancers at young age, more than one cancer in a person, like in the breast cancer as well as ovarian cancers. So these are the pointers which tell us, okay, this person has a higher chance of having a genetic syndrome, but for every ovarian cancer patient should always be tested. Now, suppose if you have an ovarian cancer patient who has been tested and is found to be positive for the BRCA gene, okay? Does it impact the further surveillance? We'll just now discuss, but what is the impact on the other family members? So if you have a genetic syndrome being positive in any ovarian cancer patient, all the first degree relatives and second degree relatives should always be tested for that particular genetic abnormality. Okay, now suppose if somebody who is a sister of the patient, okay, somebody who is a sister of the patient and she also comes out to be BRCA positive. Okay, so what are we going to do for that particular person who is positive for a genetic abnormality but yet not had developed cancer? So the important question comes of the role of what are the ways of decreasing that person developing a cancer. Okay, so if a person has found, if we have found that the patient has or the relative has BRCA gene positive, okay, for a person who has yet not developed cancer, for ovarian cancer, the problem is, and we just now discussed that it is a cancer which is not actually could be detected. We don't have methods to detect this in very early stages. The reliable screening methods are yet not present. Okay, so what is the role of other treatment modalities? What could be done for these patients? So one of the things is that they also have risk of breast cancer. So intense screening is recommended for breast. Okay, one is that you can do breast mammogram, that is the MRI of the breast, alternating with the normal usual mammogram once in 6 months. For general population, we say it is once a year recommendation or once in 2 years, but every 6 months is the recommendation for the BRCA carriers. Unfortunately, for ovarian cancer, we don't have a screening method. So what should we do? Maybe we should remove the ovaries, isn't it? If you have a higher chance of ovarian cancers, we ask the patient that, okay, please remove your ovaries. But then comes an important question. If the family is not complete, what should that person do? So there comes the role of Dr. Shweta, and she will explain this further.
So, it's very easy to say. I think that when we
Yes.
say remove your ovaries, it's a very difficult decision.
And fallopian tubes.
Yes. So I think definitely now is the role of fertility preservation. It needs to be discussed. There are multiple conditions where now we are discussing fertility preservation. One, she said that there is a genetic predisposition, and we think that this could land up in early, ovarian cancer. We don't know yet. It is not developed. So the discussion to young girls should be that they can freeze their oocytes. So if they have attained, puberty, and then yes, they can go ahead, we can do the counseling. Before puberty also, if you know that they are carrying and there is a chance and patients are so worried, though in this situation I don't think I've come across where we'll think of an ovarian tissue cryopreservation, but later in life, in early 20s or 30s also, and they found out that they are positive, then we must discuss oocyte cryopreservation if they are not married. If they are married and they want to make an embryo, they can go for an IVF with embryo formation and preservation. Not only that, extending the indication, there are certain situations which are called cancer predisposition syndromes. Now, what is a cancer predisposition syndromes? There are certain situations where you know that you are harboring this disease, or maybe your one child is affected with one of the cancers, and you know that this is genetic in origin, and you don't want your other child or your family members or your relatives' children to go through it, then you can actually do the whole gene mapping, which we are doing it. You can make a probe against this particular genetic mutation, and we can offer them IVF with pre-implantation genetic testing on the embryos, which is called PGTM, and we can have a disease-free embryo, and this will help in disease elimination from the family. So this is very important, that now it's not only just diagnosing it in the present person, but it is also preventing further transmission of this defective gene to the other, to your progeny, also detecting it in the families, and it's like a disease elimination. So these are the two things which I think even I want to bring forth this time over here in this discussion, that okay, we are talking of ovarian malignancy or cancer, but very commonly we come across endometriosis. And now the standard recommendation is that a young girl with large endometriotic cyst, rather than operating her out and out and reducing her ovarian reserve, discuss fertility preservation, which is oocyte preservation. So on an average in a year, if we do over 1,000 IVF cycles, roughly about 100 or 10% are fertility preservation, whether they are for malignant or non-malignant conditions, or maybe less than that. The awareness is still low. I'm sure that after this discussion, this awareness would be there. This needs to be spread. So in endometriosis, in young girls, severe endometriosis, fertility preservation needs to be discussed.
Yes, I agree completely. It's very easy to suggest surgeries, but very
Yeah.
difficult for certain group of population. But like, so I think one of the reasons that we wanted to mention the Angelina Jolie example is that she went ahead with surgery for the bilateral mastectomy to reduce the risk of breast cancer. And once the family was complete, she went ahead with the ovarian removal too. So because of this example, actually in throughout the world, there was just a lot of talk and awareness regarding the hereditary cancer syndrome. So she deserves a credit for that. So we,
Yeah.
yes,
You
please,
go
Dr.
ahead.
Shweta.
Yeah, please go ahead.
Yes, so I think we were also touching upon the various other risk factors, and maybe Dr. Shweta can just elaborate on the list of the various other risk factors for the ovarian cancer, and then we can proceed further.
See, one of the important ones which I told in the beginning of the
Yes,
conversation was multiple ovarian stimulations,
agreed. Yes.
right? We have already spoken about BRCA positives or other genetic disorders.
So when we talk about multiple, what is the meaning of this multiple?
So multiple means, see, what happens is the recommendation is when an infertile couple comes to us and we start stimulating her ovaries to produce her egg every month. So there is a definite limit, an upper ceiling which has been recommended that in a life cycle of a reproductive age woman, we should not be subjecting her to more than 12 cycles of ovarian stimulation. Okay. So like a very commonly given drug is clomiphene. There is not much mention on letrozole, but because clomiphene was used as a primary ovulation induction drug. So the recommendation is, and the same holds true for, because multiple corpus lutea are forming, multiple ovulation surfaces are being formed, and that is causing like a precursor for ovarian cancer, epithelial cancers. So I think this is very important that when you are giving these drugs, you need to divide your practice as whether you can do a level 1 practice in infertility, which means simple ovarian stimulations. They're not getting pregnant. You can send them to level 2 who can do laparoscopies or IUIs. And then a particular time comes where they need to be sent to level 3, where an IVF can be offered. So basically, in reproductive age group, what we need to be very important is that they complete their family as soon as possible with the least interventions. Now, OC pills in the premenopausal women, they suppress ovulation and they're protective. They're protective against ovarian cancers. But of course, in postmenopausal women, we don't want to give hormones because that can be a predisposing symptom. So I think it comes down to reduce obesity. Of course, you can't help it, the later age of marriages or an unmarried girl if she wishes to stay the way it is. But after, I guess, 40 years of age, a screening, how you go for an executive health checkup, which should also include a pelvic ultrasound, and an annual ultrasound is something what can be adopted by women after the age of 40. Of course, if there are any Mullerian abnormalities, and I would say very commonly, I'll tell you, see, the cysts, what we come across are endometriotic cysts. Then you have dermoid cysts, teratomas, so there can be suspicious symptoms in it, which we have already said, solid tumors, any suspicious solid excrescences, or if there's ascites along with an ovarian cyst, so they should raise an alarm, But Dr. Priya, I wanted to know now, see, I come across a lot of borderline ovarian tumors also, and where conservative surgeries has been done. I think that is one more area where a very quick fertility needs to be done, or a fertility preservation. So I want to know that as an oncologist, at what stage of the disease you would say, okay, we can conserve the ovary and they can then go ahead with fertility in younger population? And at what stage you would say that, no, now, it's time to just have a complete surgery?
So, like I said, Dr. Shweta, that we touched upon the evaluation to see the extent of disease. Now, once the evaluation has been done, a diagnosis has been made, and we have decided that whether a patient has completed the family or not, we need to sit down and decide on the treatment of the cancer. Now, every hospital now has a system of tumor boards. Every cancer patient is brought to the tumor board. The case comes to the tumor board, which is attended by a multi-specialty team. So you will have a medical oncologist, you have a surgeon, and you will also have a pathologist, a radiation oncologist, and the radiologist. So the whole team will sit down, they will open up the scans, they will see what are the priorities and the preferences of the patient that has to be taken into account in any decision making. And ultimately will decide what is the best foot forward. Okay, now if fertility preservation surgery can only be done for a very limited and selected patient. So, when you have a disease limited to one ovary, okay, and that too, so we always do a staging workup of the tumors. So you have a stage 3 tumors, you have a stage 4 patient. Now for stage 3 and stage 4, it is usually not recommended. For stage 1A, maybe 1A, yes, very much possible, because it is limited to only one side of the disease in the one ovary. Whenever we open up and do the surgeries of the ovary, it's very much important that you also take sample from the other ovary. There are some patients, they will have disease limited to one ovary in the scan, but during the intra-op, they might have disease in the other ovary. So it's very important that the sampling of the contralateral or the opposite ovary should always be done. And only after ensuring that the cancer is not there, you can actually proceed with fertility preservation. A detailed examination of the abdominal cavity is very much needed and is always done. So there should not be any disease. The uterus should be okay. The disease should mostly be limited to just one ovary. There should not be any other deposits. So very early and selected patients can only go forward with ovarian preservation surgery. So I think.
So I wanted to put one more point.
Yes.
But what happens is sometimes we are in the era where everybody wants to get a laparoscopic surgery done.
Yes.
So it's very important to
We have robotic too.
Yes, to have a judgment that which
Yes.
patients can be treated laparoscopically, and we should
Yes.
not be hesitant that which patients need a complete staging laparotomy with no spill of the ovarian tumor. So if you have a great suspicion, okay, there is no harm in doing an open surgery.
Agreed.
Secondly, for borderline tumors, also, once they have completed their family, they need to be under very strict surveillance.
Yes.
Because what happens is very close associate. I remember had a borderline tumor. After the child is so happy, completely forgets and lands up in a full blown, a metastatic ovarian cancer. So that is something which should not, be missed in India, because we are such a populated country that we don't have a system to send people. We are not even able to reach a universal pap smear in LBC in our population. So, calling these patients back becomes a responsibility maybe of the patient, but sensitizing these patients that they need a close follow-up, sending them back to the oncology team is so important. Having a protocol made that, and just having fertility completed is not the end of the answer. This surveillance is lifelong, it is long term, and that is what we are looking at. Now, are there any rare types of ovarian cancers which you have come across? Like, say, in my age group, one is testicular feminizing syndrome, and where it becomes very important that all cases who come with primary amenorrhea, we always get a karyotype done, because we can have Turner mosaics who need gonad removals. We could have XY, which is testicular feminizing syndrome, or Swyer syndrome. And then we could have younger patients coming with yolk sac tumors or dysgerminoma. So we need to, be very vigilant when it comes to younger patients with ovarian masses or a genetic component which is little aberrant. Now, let's go to the elderly population. That are there any atypical types? And there was a question in the chat box which said that what about, other than BRCA, what about HRD mutation and its implication on treatment?
So yes, so a lot of things have happened now in the ovarian cancer sphere. So how do we treat an ovarian cancer patient? So one is that once you have discussed about the management, there is a group of patients who have very early stage disease, and sometimes you need to discuss the option of fertility preservation. But on the other end, you also have the patients who have advanced stage disease. Like the patient's most common presentation is usually in the stage of 3 and 4. The most common histology subtype that we see is high-grade serous, isn't it? So stage 3 and stage 4 are the group of the patient where the chances of recurrences are also very high. So what do we do is that usually these patients are started on chemotherapy first. So paclitaxel, carboplatinum are the usual treatment choices, but you also have liposomal doxorubicin and carboplatinum based regimen. You have another option of cisplatin based chemotherapy, but now there is a data that the carboplatin is better as far as the tolerability is concerned compared to the cisplatin based regimen, and the efficacy is the same. So now the data says that the carboplatinum based regimens are patients are started on these treatments. Now, the purpose of giving chemotherapy before surgery is that you want to shrink the tumor. That helps to decrease the post-op complication rates and improve or hasten the post-op recovery period. We still don't know if that actually, so you have another option of doing upfront surgery, isn't it? So we still don't know if doing an upfront surgery versus giving neoadjuvant chemotherapy, the so-called chemotherapy before surgery, whether the long-term survivals are impacted or not. But overall, this strategy helps to decrease the tumor burden, and so that the ease of surgery is also is ensured. Now the thing is, there is another drug which has come in this sphere with bevacizumab. Bevacizumab is VEGF inhibitor. What is VEGF inhibitors do? They act on the tumor blood supply, and again they help to reduce the tumor size. So you start the patient on chemotherapy plus bevacizumab. You do your surgery after usually 3 cycles of chemotherapy. We follow a schedule of 3 weeks. Why do we give this gap of 3 weeks? 3 weeks gap is given so that the body adequately recovers from the side effects of chemotherapy and is ready to take another chemotherapy. So 3 weeks, 3 cycles are done, then you do surgeries, and after that again chemotherapies are continued. So this is for another 3 cycles. But yes, we know that for stage 3 and stage 4 cancer patients, they have a very high chances of recurrence. Up to 70 to 80% of patients will actually recur at some time point. And that is why, in order to decrease the recurrences, lot of strategies have come. The one strategy is that you just continue bevacizumab at least for 1 year. But what else can be done? And that is why it's very important to see this BRCA report. Now, in addition to BRCA report, there is something called as HRD. HRD stands for Human Recombination Deficiency. Now, what is HRD, or why should we look for HRD? So what happens is when the cancer is an interplay of genetic mutations. So a mutation makes our genome quite unstable sometimes, and HRD is a estimation of that particular instability. Okay. So you can see for the test, you can see for the mutations in the genes, and you can also see the instability of the genomes. Okay. So that will help us to predict if a particular drug can be used to decrease the chance of recurrence. So now, as a routine, we are doing BRCA testing and we are also doing HRD testing. Up to, so like I said, that up to 20% of the patient might be positive for BRCA, but up to 50% of patient might be positive for HRD. Okay, so HRD is a very recent concept. It has come now in the ovarian cancer, but it's also picking pace in breast cancer and prostate cancer. So if the BRCA is positive or if the HRD is positive, we know that there are certain groups of drug which goes by the name of PARP inhibitors, that these patients are going to respond to these drugs, and these medicines can be used to decrease the recurrence rate. So you have done your chemotherapies, you have done surgery, you have again done chemotherapy. So this is what is sandwich treatment that we say. And then you put the patient on, you have done these tests, and you have put the patient, if they are positive, you put them on these tablets. So these tablets, there are 3 or 4 options that we now have in our Indian space, that you have olaparib, you have rucaparib. So in a patients who have olaparib, you have these abnormalities present, we tend to put them on these maintenance, PARP inhibitors maintenance strategy. And this now the data is to suggest that using these maintenance strategies actually decreases the death rates, recurrences rate both. So there is both improvement in PFS, event-free survival, as well as overall survival by use of these drugs in this particular patient group. So 50% of HRD is actually, it's a good number. You're talking about half the patients of ovarian cancer. So that way you're able to help a big number of patients just by doing a single test. And that is why it's very important that in no ovarian cancer patient, these tests should be missed, because there are intervention strategies which can decrease the recurrences rate. So I think that is why the HRD, doing an HRD testing is very important. Doing a BRCA testing is very important. BRCA in addition will also give you information about the hereditary component part, isn't it? So whether the patient also has increased risk of breast cancer, whether the family members needs to be tested or not. So always HRD in the tumor and this BRCA in the blood should always be done for all ovarian cancer patients. Now, talking about what are the other rare subtypes of ovarian cancer? Like I said, that the serous ovarian cancers are the most common ones, high grade serous. The other rare subtypes is low grade serous. You also have clear cell, mucinous, and one of the other tumor is endometrioid. Mucinous is actually seen in young females, and it's one of the cancers that happens in smokers. So smoking is also one of the risk factors, and for cancers. And mucinous are usually cancers happening in your GI tract. So if you have a cancer when you get a mucinous, you should always investigate that patient for the GI tract tumor also, because those are the one more common. Then, like I said, in the Lynch syndrome, you can get the mucinous cancers. And sometimes the guidelines say that the mucinous cancer should be treated, the chemotherapy choices are on the lines of GI tract treatment as well. One of the surgical advancements have happened, the role of robotic surgeries to decrease the complications, and also the role of HIPEC has come, which means that installation of chemotherapy directly in the abdominal cavity after the complete surgical cytoreduction has been done at a slightly elevated temperature, that helps to decrease decrease the disease burden. So HIPEC is something which has now come up and it's being done in a lot of centers in India. So if Dr. Shweta wants to add something to these, she's more than welcome.
So that is completely not, my forte, and I think I'm getting pretty, knowledgeable hearing what oncologists have to do. So let's, have let's take it this way that, of course, gynecologists cannot function separately. We need medical oncologists, and medical oncologists also need to be sensitized, I would say, especially for younger population, right? That there has to be a to and fro communication, which needs to be done when it comes to fertility preservation. See, my issue comes is that we have a very robust medical oncology unit, and you also I am in Gangaram Hospital, you are in Artemis. But the number of patients who are actually going for fertility preservation for various reasons is still less. So it comes down to maybe the diagnosis also. So awareness. I think there has to be, when we do all our medical camps, I remember very recently we have started all pan India. We talk about cervical cancer. We talk about breast cancer. But of course, since there are no robust screening methods, so the ovarian cancer is less talked about. So is there a way you can think that we can, because possibly I can think of, don't ignore the symptoms, any unusual symptoms, any symptoms persisting, any abdominal lumps you are feeling, because there are so many occasions. Now, I can give you one example. I operated on a girl 4 years back for a fibroid. She never comes back for a follow-up, and then she comes back with a uterine size which is close to 32 weeks pregnant uterus. So that is ignorance, I think, even on the part of the patient, that they have such a huge mass in their abdomen. They've not been feeling it, and no robust systems where we could have tracked these patients, call them back. So I think those systems also need to be developed in India, where there has to be an electronic way to inform the patient that you are due for your checkup and you have not returned back. So I think these systems need to be developed. When the patient gets discharged after your treatment, what is the long-term follow-up? I think that specially needs to be discussed, because unless we detect them young, unless we detect them early, we cannot, save our population. If we're looking at a 5-year or a 10-year survival rate, if we have to increase it, then we have to catch them early, right?
Oh,
There is
that's
a
very rightly
question in
said,
the
yes.
chat box again. Ovarian cancers only affect older women or even middle-aged women in 20s or 30s. Any suggestion to common test females of middle age, which we have already, I think, mentioned, that we have to keep a watch on the symptoms. This is one. If there is any family history which needs to be discussed with your, gynecologist, because they will be the first one where patients would be actually coming back to. And any untoward ultrasounds, I think, need to be investigated. So these are the few. The genetic testing definitely comes in, and I think in our hospital and even in yours, when I was having a word with our oncology team, they said we are advising like a BRCA to all the patients with ovarian malignancies now, irrespective of the age. So genetic counseling, which Dr. Priya just mentioned, is very, very important. Now, genetics is in every condition and every organ of our body. And the only way to track whether we have a high predisposition is by doing a proper genetic counseling. So these are the few ways I think we can detect whether they are young or they are in the matured age. Should we
Yes.
have some, yeah, anything else
Yes,
you
I
want to
think there's
add on?
just one more question actually. As
Yeah.
you mentioned about recurrence being common in ovarian cancer, how do you monitor patients under remission?
Yeah.
Yes, a very important question. So I think, so I'll tell you something, the wisdom and the science part of it. See, when you have a patient, we tend to monitor with when you have treated patients, okay, you have treated the patient, you start the follow-up plan. So we know that the recurrences are seen most frequently, like within the first 2 or 3 years. So we keep more stringent follow-up plans then. So we do like 3 monthly follow-up, then later on we make it 6 monthly. So first 2 or 3 years we do 3 monthly follow-up plan. So as a part of the follow-up plan, you have to examine the patient, ask about the symptoms such as bloating, any new symptom happening in the body. Importantly, people tend to do CA-125. People also tend to do pelvic ultrasound or abdominal ultrasound during the follow-up. Now we have to understand that the disease can happen even with the markers negative, but at some point of time, if there are symptoms, the patient should be investigated. The other part is that if you have a rising CA-125, then you will definitely want to investigate that patient further with maybe another MRI or doing a PET scan. But what the guidelines say is that just isolated biochemical rise in CA-125 should not be treated with chemotherapy. You have to establish a recurrence either symptom wise or at least by some imaging, and then only you should treat the patient. But what is most important is that you should stringently follow up, you should make a follow-up plan and follow up your patient quite regularly, because what happens, sometimes patients are lost to follow up because they get this notion that once the cancer is treated, it is not going to come up, and sometimes they will just, like Dr. Shweta said, will emergency with severe maybe obstruction. There could be masses compressing on the intestine, so they can just come up in this with intestinal obstruction and few other problems. Okay, now the problem is when the patients have a lot of symptom burden, the treatment tolerance also becomes poor, isn't it? So it becomes, anyways, the prognosis becomes bad. So it's very important that the patient should always be investigated and recurrences should be caught and patient should be treated well in time.
So I wanted to put in one important advice to all the gynecologists who are attending, that whenever you are operating on any tissue, whether it may be fibroids, it could be adenomyosis, it could be endometriotic cyst, clinically, these are dermoids, but sending the tissue for histopathology is of utmost importance.
Agreed.
There are so many occasions, even today, I see reports where the patients have been operated. Even if you operate on a simple cyst, you have seen that it's clear full fluid, we need to send that tissue for histopathology. Now, in my reproductive medicine, so many times I see endometrium is sent just for TB PCR, just for tuberculosis. But no, the first test to be done is histopathology. You need to rule out hyperplasias in the endometrium, CNC2, borderline ovarian tumors, any full-blown malignancies. So sending the tissue for histopathology is of utmost importance, even if you do the most minor, because that is, and we are in the medical legal world, so we have to be very careful. This is very, very important. And if there is any, solid tumor you are operating, you have to ensure that there is no spill, because then you are upgrading the disease just because of your surgical intervention. And suddenly this girl will end up getting chemotherapy. Maybe she was just destined to go through surgery, and that would have been the end of her procedure. So I think it's an interplay. You will even need a counselor, because these girls could be having a lot of psychosocial problems. They could be going through depressions. So we will need a medical oncologist, we will need a gynecologist, we will need a surgical oncologist, we will need a counselor, and this is a reproductive medicine specialist, and later on maybe a palliative team where nothing can be done. At least the quality of their life is something what, warrants for. So, every tertiary care center should have a palliative medicine department where if you cannot operate on them further, none of the chemotherapies are working, but at least the pain relief is there and they have a better quality of life.
So I think Dr. Shweta touched upon a very important part, especially the counseling part. So
Yeah.
most of the time, the patient, they don't themselves realize that they need a counseling, but there are just so many thoughts going on in the mind of patients and also in the mind of caregivers that it's very important to talk to a counselor so that you can just find answers to segregate your thoughts in your own head, to streamline your own thinking. A lot of patients always have these problems of like, why me? Maybe I have done something wrong. So there's a lot of self-directed anger. There's a lot of guilt. Also, they feel that they are being burdened over the family. So I prefer that most of the patients, and especially females, they don't want to be burdened on anybody, isn't it? We are the upbringing is like that. They are supposed to take care of everybody. So especially with females, this is a very common problem. So I think they should always at least make sure that they are attached to a counselor, which helps them in the ways that we won't be able to.
So even having cosmetic aspects to these
Yes.
should be, I think looked into, like when they're going through chemotherapy, they will have hair loss. So, giving them a good hairdos, things, very small things, or people are talking about, special after the breast surgeries. So cosmetic part also, I think, has to be looked into, the kind of diet these girls, women will be going through. So it is not just, I think, medical approach, but it is a whole holistic approach. I remember very recently I went to Raipur and I felt like meeting a patient of mine, very young, very pretty girl, and because she had a yolk sac, a tumor, and she had to be operated. The one ovary is conserved, and then she had her embryo preserved, and then she comes with a cap or she's done a hairdo, and then I realized that the kind of anxiety, psychological issues, even gastric issues this girl has been having. She's very worried about the look she's going through. So I think empathy, sensitization, and holistically looking after everything, including even the cosmetic look, is very, very important.
I think that beautifully sums it all.
Yeah. So I think, is there anything else? Last, maybe one statement from you and from the medical team of Cipla. Dr. Sucheta, if you can come into picture and we can maybe sum up, and if there are any questions, we can take over.
Ma'am, I guess due to some glitch, she got.
My video is not working, and there is a session of Ganpati Visarjan happening just now. So,
Yes,
Preeti,
it's
can
the
you
same
just
problem
help?
here too.
Yes, sure, ma'am. Ma'am, since we are towards the end of the talk and conversation, it was really interesting. Just quickly, if you both can share a quick take-home message for doctors from this overall talk.
So I'll go first.
Sure, ma'am.
Yeah.
So yes, so important thing is about ovarian cancer is understand the symptoms, identify the red flag, and investigate until you are confident that you are not dealing with ovarian cancer. Because if you miss an ovarian cancer in early stages, we know that later stages presentation, though are treatable, leads to increased chances of recurrences. We also have to understand that there are strategies now available which decreases the recurrence rate. And it's very important that a genetic component should always be checked in a case of ovarian cancer. Now, having said that, there are strategies to reduce the cancer incidence in the patients, in the person who has been diagnosed with ovarian cancer carrying gene. Okay. So yes, it's very important that you also sensitize not just the cancer patient, but also the family members, so that if cancer patient is positive, we also do the test in the relatives. At the end of the day, any cancer, the chances to decrease the risk of cancer having can be actually decreased by following a healthy lifestyle. Your diet, which is rich in salad, a diet which is rich in fruits, and if you adequately exercise, then yes, your chances of cancer also goes down. So take care of your body weight, your lifestyle, identify the risk factors, symptoms, and be healthy.
So, adding on, Dr. Priya has very beautifully summed up. I think when it comes to awareness, I'm sure we all are aware now, and we will be more vigilant. I think we need to be, and not ignoring the symptoms. The second is, I think underdiagnosing is bad because you are missing on the cancers, and overdiagnosing is also bad because then you are unnecessarily treating and causing interventions, and maybe a young girl will lose an ovary. So, the right modality of suspicion, the right test, and the right interpretation is also very important before you take of, because any action in cases of a suspected ovarian mass can be very drastic. Secondly, I would say, being from the reproductive medicine unit, that yes, fertility preservation should always be in the mind. For families, we need to sensitize. We are in the world where ovarian, all the fertility preservations have excellent results, especially the oocyte cryopreservations. In the best of the centers, they have excellent results. We should give the best quality of life. We have heard beautifully from Dr. Priya that, so many chemotherapeutic drugs, targeted delivery systems are available, and I'm sure that they make the best protocol for the patients. So many tumor markers have come in. Without genetics now, nothing happens in our field. So I think more awareness, right diagnosis, and sending every tissue for histopathology is so important. It is mandatory. So thank you so much. And thank you, Cipla team, for calling us today. And it was lovely talking with Dr. Priya. And I
Thank you,
hope
Dr.
that,
Shweta.
we have done some justification.
Thank you so much,
Thank you,
ma'am.
Dr. Sucheta.
Yes, Sucheta ma'am is here.
Yeah, and it has been a really interesting, interactive, I think, and very informative. And I think this is just the first step that we are taking towards creating this awareness. We are going to have other talks, similar talks, more collaboration between gynacs and oncos, and also for patient awareness. We are planning many more initiatives. With that, thank you so much, both the doctors and the audience also, for making this interactive and asking questions. We'll meet up soon again, and many more programs to come. So stay tuned.
Thank you, Dr. Sujeta. Thank you so much.
Thank you, doctors.
Thank you, doctors. Thank
Dr. Shweta.
you.
It was nice interacting
At
with
the
you.
end, we
Thank you.
stand to one motto, that is every woman matters.
Yes.